Imagine a 56-year-old woman, right? And she wakes up with a sudden, just severe onset of genital pain.
Oh, wow.
Yeah, we are talking intense numbness, burning when she urinates, and a hypersensitivity so severe that just wearing clothes is agonizing.
Which is terrifying.
Right. And she has absolutely no history of sexually transmitted infections. So she makes the logical assumption, she thinks it's a really bad yeast infection.
Sure, that makes sense.
So she goes to the pharmacy, she buys an over-the-counter cream, and just waits for relief.
Which I'm guessing never comes.
Not even a little bit. I mean, the pain escalates until she literally finds herself in the emergency room.
Right.
And the doctors run a basic metabolic panel. They find some trace evidence of inflammation in her urine, so they just presume it's a standard UTI.
Standard protocol, yeah.
Exactly. They hand her a prescription for antibiotics, tell her to take it 4 times a day, but 5 days later, she is still in agonizing pain.
Because the antibiotics aren't doing anything.
Nothing at all.
Yeah.
Her doctors are completely baffled because they're examining her, and on the surface, her tissue looks perfectly healthy.
And that's the trap right there. I mean, they are looking for a surface-level explanation for a problem that is actually buried deep inside her anatomy.
Exactly.
The real culprit in this case study, which, by the way, we pulled straight from our stack of medical literature today, it wasn't fungal, and it wasn't bacterial at all.
No.
It was a hidden viral fire burning inside her spinal nerves.
And that terrifying reality is our mission for today's deep dive. We are taking a massive stack of case studies and research papers to try and solve this profoundly misunderstood medical mystery.
It really is misunderstood.
We want to unpack how a persistent, non-healing herpes simplex virus radiculopathy, which just means a viral disease of the spinal nerve roots, can permanently alter regional nerve pathways.
Right, the rewiring process.
Yeah, we want to show you exactly how it causes chronic post-herpetic dyspareunia, which is the clinical term for severe, unrelenting pain during intercourse.
To even begin to understand how this happens to a person, we have to kind of completely throw out the cultural definition of herpes.
Let's do it.
When most people hear herpes simplex virus, or HSV, they immediately picture a skin condition. Right.
Yeah, like a rash, a cold sore, a blister, that sort of thing.
Exactly. But the sources we're looking at are very clear that defining it as just a skin condition is a fundamental medical misconception.
It's way deeper than that.
It's actually a neurotropic virus. So neuro meaning nerve, and tropic meaning having an affinity for.
Okay, I gotcha.
HSV2, which is the strain most commonly associated with genital infections, it literally prefers to live inside the human nervous system.
It's like a highly specialized nerve invader.
That's a great way to put it. Once a person has an initial infection, the virus doesn't just clear out of the body like a common cold would.
Right.
It retreats inward and establishes this lifelong dormant home deep within the sensory ganglia.
Wait, hold on. I'm a little confused here.
Sure.
If we are talking about a pelvic or genital pain condition, why are we suddenly talking about the sensory ganglia near the spinal cord?
That's a fair question.
I mean, if a woman has severe pain in her vulva, her affected nerve endings are down there, right in the tissue. Why is the virus setting up camp all the way in her spine?
It's all because of the way our body's wiring is mapped out.
Okay.
The virus is essentially looking for a permanent base camp that is totally safe from the local immune response at the skin level.
So it runs away from the scene of the crime.
Exactly. It travels up the nerve fiber like a highway, moving away from the genitals until it reaches the sacral dorsal root ganglia.
The sacral ganglia, okay.
Yeah, if you picture your own body right now, reach around to your lower spine, right down by your tailbone. We are talking specifically about the nerve roots at the S2, S3, and S4 dermatomal levels.
Okay, I actually saw that exact term in the research, dermatomal levels.
Yeah.
Let's define that for the listener really quick, because it seems critical to understanding why the pain manifests where it does.
Oh, totally. So a dermatome is basically just an area of skin that is supplied by a single spinal nerve.
Like a zone.
Right. Picture a neurological map of the human body. Instead of being divided into organs, it's divided into these horizontal bands, kind of like a topographical map.
Oh, that makes sense.
Every single inch of your skin is wired back to a specific slot in your spinal cord. And the S2, S3, and S4 slots at the very base of your spine, those are the exact origin points for the pudendal nerve.
And the pudendal nerve is like the master cable for the pelvis.
It really is. It provides the vast majority of sensation to the entire pelvic floor, the perineum, the anus, and the genitals.
Wow.
So by retreating to those S2 through S4 ganglia, the virus has essentially hacked into the central junction box that controls all feeling and function for the most sensitive areas of the lower body.
It's just sitting there.
Yeah, just quietly incorporated into the very cells that are responsible for transmitting sensation to your brain.
Okay, so I followed the anatomy. But structurally, how does a virus sitting completely dormant in a spinal junction box cause a visible sore on someone's skin?
Well, under normal circumstances, the virus occasionally reactivates.
Like it wakes up.
Right,
But
and this can be triggered by a drop in immunity, heavy stress, or even just hormonal shifts.
sure.
When it wakes up, it gets back on that nerve highway. It travels all the way down the axon of the pudendal nerve, moving outward until it reaches the nerve ending at the skin surface.
And that's where it causes trouble.
Exactly. It sheds, causes local inflammation, and boom, you get the classic visible blister.
Okay, but our sources highlight a totally different scenario, right? Like a terrifying detour, which actually explains our 56-year-old woman in the ER.
Yes.
Because sometimes the virus reactivates, but it doesn't make the commute to the skin at all.
Right, and this is where things get really complicated. Instead of traveling outward, it aggressively replicates right there within the ganglion itself.
Wow.
It causes severe inflammation inside the nerve root. It's a condition called viral radiculitis, or ganglionitis.
You know, it's like a house fire burning entirely inside the electrical wiring within your walls.
That is a perfect analogy, yeah.
Like, the paint on the outside of the house looks absolutely perfect. You could stare at the drywall all day and not see a single scorch mark.
None.
But inside the walls, the wires are just melting, the alarms are short-circuiting, and the internal system is being completely destroyed.
And that internal destruction? It translates directly to intense neuropathic pain, urethral burning, and extreme hypersensitivity for the patient.
But the skin looks fine.
Exactly. When the doctor does a visual exam, they see absolutely no scorch marks. The skin is pristine.
So the doctor assumes the problem must be something else entirely, which leads to endless misdiagnoses.
It's a really frustrating cycle for patients.
To prove just how aggressive this internal swelling can be, I actually want to bring up Dr. Charles Ellsberg from the literature.
Oh, yes. The history here is fascinating.
The medical history in these sources is just wild. We are going back almost a century, right? To 1931.
Yeah, 1931. Dr. Ellsberg was a very prominent neurosurgeon, and he started seeing these highly unusual patients.
What were their symptoms?
They presented with sudden, just massive neurological deficits in their lower bodies.
Like what?
Like acute urinary retention, meaning their bladders just completely stopped functioning. They had severe bowel dysfunction, numbness running down the backs of their legs,
Oh my God.
and a total loss of basic reflexes in the pelvic region.
Wow. I mean, if you are a neurosurgeon in 1931 and a patient presents with those symptoms, your immediate thought has to be that something massive is physically crushing the base of their spinal cord.
Absolutely. You'd assume there's a large spinal tumor pressing on the cauda equina, the bundle of nerve roots at the bottom of the spine.
Right.
So Dr. Ellsberg took these patients into the operating room. He made the incision, opened at the lower spine, fully expecting to have to excise a massive tumor.
But he found absolutely nothing.
Nothing. No tumor, no structural mass, no physical compression whatsoever.
That must have been so confusing.
Completely. The only anomaly he found was that the cerebrospinal fluid was cloudy.
Cloudy.
Yeah. And when they analyzed it, they found elevated white blood cells, which indicated a severe immune response, like a massive inflammation.
Right.
But he closed the patients back up, entirely mystified. And strangely enough, over the course of several weeks or months, many of these patients just slowly regained their bladder function and got better on their own.
Wow. And it became known as Ellsberg syndrome.
It did.
And it remained a medical mystery for decades. I mean, it took the invention of PCR testing, polymerase chain reaction testing, to finally solve it.
Yeah, PCR changed everything. It's essentially a molecular photocopier.
Let's unpack that a bit.
So it allows scientists to take a microscopic, like almost undetectable trace of DNA in a sample of spinal fluid and amplify it millions of times until it's large enough to actually be identified.
And when modern doctors started running PCR tests on the spinal fluid of patients presenting with Ellsberg syndrome, the molecular photocopier revealed the invisible culprit.
It was herpes simplex virus all along.
Just incredible.
The virus was reactivating in that S2-S4 sacral region and triggering such massive localized neuroinflammation that the pudendal nerve roots were swelling and just temporarily shutting down.
So it proved definitively that this virus is perfectly capable of causing profound structural neurological damage, all without a single mark on the skin.
Exactly.
So Ellsberg's patients were temporarily paralyzed, right? But they mostly recovered as the acute inflammation died down.
Right, eventually.
Which brings us to the core of our mission today. How does a temporary viral flare turn into a permanent chronic pain condition?
That's the million-dollar question.
We're looking at patients who have dyspareunia, severe pain with intimacy that lasts for months or even years.
Well, to understand the transition from an acute flare-up to chronic, non-healing pain, we really have to look closely at the microscopic architecture of the pudendal nerve itself.
Okay, take us down to the microscopic level.
When the virus replicates inside the nerve root, it causes direct physical trauma.
Right.
And on top of that, your body's immune system rushes in to fight the virus, flooding the area with inflammatory chemicals.
Kind of like a biological war zone.
Exactly. This combination of viral damage and severe inflammation causes actual structural injury to the nerve fibers.
And the sources mention the awakening of normally silent C fibers.
Yes.
Let's break down what those are, because this seems to be the exact moment the permanent rewiring actually happens.
It is. C fibers are a specific, very thin type of nerve fiber responsible for transmitting slow, aching, burning pain signals to your brain.
Okay.
In a healthy pelvic nervous system, many of these C fibers are what we call silent,
Meaning they don't do much.
meaning they have a very high threshold for activation. Yeah. They're designed to only fire off a pain signal in response to severe actual tissue damage, like if you were to sustain a deep cut or a severe burn.
Okay. But the trauma of the virus living inside the nerve essentially breaks their threshold.
Right. It wakes them up.
You know, I look at this sensitized nerve like a broken car alarm.
Oh, I like that.
Like in a brand new car, the alarm sensor only triggers when a real threat occurs. Someone smashes a window or tries to pry the door open with a crowbar.
Yeah, it takes a lot of force to make the alarm sound.
Exactly. But after the structural damage from the viral radiculopathy, the alarm sensor is fundamentally broken. The threshold is lowered to near zero.
Completely broken.
Now, instead of only going off for a smashed window, the blaring siren triggers just because a leaf blew against the windshield, or a truck drove by too loudly.
Exactly, yeah.
The alarm is just constantly screaming, "Danger," for no valid reason.
And in neurology, we call this clinical phenomenon sensitization.
Sensitization, okay.
The nervous system becomes hypervigilant and just pathologically overreactive.
Right.
The medical literature uses two specific terms to describe how this broken alarm system manifests in a patient's everyday life:
What are they?
allodynia and hyperalgesia.
Okay, what's the practical difference between those two? I mean, if I'm a patient experiencing this, what does it actually feel like?
So allodynia is when your brain registers a completely normal, non-painful everyday stimulus as excruciating pain.
Like what kind of stimulus?
Imagine wearing a pair of jeans, and the simple friction of the denim brushing against your skin feels like a blowtorch.
Oh, that's awful.
Or the gentle pressure of sitting on a bicycle seat, or even a light, reassuring touch from a partner. It sends a blaring 10 out of 10 pain signal to the brain.
That's just terrifying. And what about hyperalgesia?
Hyperalgesia is an exaggerated, amplified response to something that is normally mildly painful.
Okay, so it amplifies it.
Right. A tiny pinch that should just be a quick ouch feels like a deep stab wound.
Wow.
And what makes this so insidious is that this sensitization doesn't just stay localized at the tips of the peripheral nerves in the pelvis. It actually travels upstream.
Like a system-wide rewiring?
Precisely. The constant barrage of false pain signals causes the dorsal root ganglion to become permanently sensitized.
Which alters the spinal cord itself.
Yes. And eventually, the way your physical brain processes pain is fundamentally changed.
So if we take this system-wide sensitization and apply it to our deep dive topic today, chronic post-herpetic dyspareunia, the connection becomes pretty glaringly obvious.
It really does.
Because sexual intimacy inherently involves mechanical friction, right? Stretching and pressure on the tissues of the vulva, perineum, and pelvic floor.
All of which are innervated by that virally damaged pudendal nerve we talked about.
Right.
For a healthy person, that mechanical friction is processed by the brain as pleasurable or, at least neutral.
But for a patient with this condition, that normal movement is hitting those awakened silent C fibers.
The leaf hits the windshield and the broken car alarm goes off.
Exactly.
The sources specifically note that something as subtle as the movement of pubic hair against the skin can trigger these hypersensitized branches.
Just the hair.
Just the hair.
Yeah.
The brain interprets that normal friction as burning, electric shocks, or stabbing pain, which makes intercourse entirely impossible.
That's devastating. But the nerve damage isn't just an isolated broken wire, is it? The body is an interconnected biomechanical machine.
Very much so.
When the brain senses that a nerve in the pelvis is constantly screaming in pain, it naturally tries to protect it. And according to the research, that natural defense mechanism actually makes everything significantly worse.
Yeah, you're talking about the secondary pain loop.
Let's unpack that.
Well, the body's natural response to severe localized pain is to guard the area. It tries to splint the injury.
Okay.
So the nearby pelvic floor muscles, which run along that exact same pudendal nerve pathway, they begin to clench. They tighten up to protect the nerve, but over time, they develop chronic spasms.
They get locked in a Charlie horse that just never releases.
Exactly. And those chronic spasms create trigger points, and they generate their own local low-grade inflammation.
So it's compounding.
Right. You now have tight spasming muscles acting as secondary irritators. They physically squeeze and compress the already virally sensitized pudendal nerve.
It's a devastating, vicious cycle.
It really is.
The viral nerve damage makes the pelvic muscles spasm, and the spasming pelvic muscles crush the damaged nerve, which amplifies the pain even further.
Right.
Which perfectly explains why this condition doesn't just magically heal on its own with time. The entire pelvic region is locked in a biological panic state.
And if a patient caught in this loop goes to their gynecologist or urologist, the standard diagnostic exams are going to come back completely normal.
Right, because they can't see it.
The doctor does a visual inspection. No blisters. They run a urine culture. No bacteria. They do a vaginal swab. No yeast.
So how does a specialist actually treat this? I mean, if you can't see it and standard tests can't find it, how do you break the loop?
It requires a physician who really understands neurobiology and who is willing to treat the nervous system rather than just the superficial tissue.
That makes sense.
The medical literature points to a two-pronged approach.
Okay, what's step one?
The first step is to turn down the volume on the virus itself. Even without visible blisters, if the virus is frequently reactivating internally and causing that invisible fire, doctors will utilize a therapeutic trial of suppressive antiviral therapy.
Okay, so we're talking about daily medications,
Yeah.
things like acyclovir or velociclovir.
Exactly.
How do those actually work, though? Do they kill the virus?
No, unfortunately, we don't have a drug that can eradicate HSV from the ganglia.
Oh, really?
Yeah, it's permanent. But antivirals like acyclovir work by interfering with the virus's ability to synthesize its own DNA. It basically stops the virus from replicating.
Okay, so it stalls it out.
Right. Taking these daily suppresses the viral activity deep inside the sacral ganglia.
Got it.
If a patient with unexplained severe pelvic burning sees a significant reduction in pain after a few months on daily acyclovir, it strongly confirms the diagnosis.
Because it proves the virus was the hidden culprit driving the nerve irritation.
Exactly.
But an antiviral only stops new fires from starting, right? It doesn't put out the secondary fires.
That's exactly the problem.
It doesn't fix the broken car alarm or stop the pelvic floor muscles from crushing the nerve.
And that is where the second phase of treatment comes in, breaking the secondary pain loop.
Okay.
Once the viral replication is suppressed, physicians use nerve calming strategies. One of the most prominent interventions highlighted in the sources is the use of localized Botox injections.
Wait, Botox?
Yes, Botox.
When most people hear Botox, they immediately think of smoothing out forehead wrinkles. How does a cosmetic injection fix a damaged pelvic nerve?
Well, it's important to remember what Botox actually is, right?
Yeah.
Botulinum toxin is a powerful neuromuscular blocking agent.
Okay.
When a specialist injects it directly into those spasming, locked-up pelvic floor muscles, it prevents the nerves from releasing acetylcholine, which is the chemical that tells the muscle to contract.
So it forces it to relax.
It essentially forces those hyperactive muscles to finally fully let go.
So it stops the muscles from acting like a vice grip on the pudendal nerve.
Yes, but the neurological benefits actually go even deeper than that.
Really? How so?
Recent research shows that Botox doesn't just paralyze the muscle. It also disrupts the release of pain-related neurotransmitters like substance P from the sensory nerve endings themselves.
Oh, wow. So it's chemically muffling the broken car alarm.
That's exactly what it's doing.
Yeah.
It helps reset that sensitized, hypervigilant nerve pathway.
That's incredible.
By forcing the muscles to release and stopping that flood of pain chemicals, you finally break the cycle of sensitization. You give the nervous system the space it needs to finally reboot and begin healing.
Man, zooming out and just looking at everything we've uncovered from this stack of medical literature, the paradigm shift here is massive.
It really is.
For anyone suffering from chronic post-herpetic dyspareunia, this validates their reality so much.
100%.
This condition is not a psychological issue, it is not a low pain tolerance, and it is definitely not a traditional skin infection.
It is a profound structural and chemical rewiring of the pelvic nervous system.
HSV2 hides deep in the sacral ganglia. Its invisible internal reactivations cause actual physical injury to the pudendal nerve roots.
Yep.
And that trauma wakes up silent pain fibers, permanently lowering their threshold. That broken alarm system triggers severe pelvic muscle spasms, which compress the nerve further, fundamentally altering how the brain processes simple touch and friction.
You've got it. Understanding the specific neurobiology of this pain is just the vital first step toward reclaiming control.
Definitely.
For you listening, whether you are a patient desperately searching for answers, a partner trying to understand, or even a practitioner looking to better serve your patients, this knowledge is power.
It proves the absolute necessity of looking past the surface of the skin and diving into the nervous system to find the root cause of unexplained pain.
Exactly.
Which leaves us with a rather haunting thought to end on today.
Oh, what's that?
Well, we now have the concrete medical proof that neurotropic viruses like herpes simplex can cause severe, invisible neuropathic pain by permanently sensitizing our nerves long after any active outbreak has passed.
Right. And we are exposed to dozens of neurotropic viruses throughout our lifetimes.
Yeah.
It really makes you wonder, how many other chronic unexplained pain conditions are out there?
Oh, wow. Yeah.
How many mystery migraines, chronic backaches, or unexplained muscle spasms throughout the human body are actually just the invisible ghosts of dormant viruses?
Just quietly setting fire to the wiring inside our walls.
Exactly. While the outside of the house looks perfectly fine.
It completely changes how you view chronic pain. The surface never tells the whole story.
It really doesn't. Well, thank you for joining us on this deep dive. We'll catch you on the next one.